You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 16th, 2024. Our topic is Prevention of Atopy, presented by Dr. Christina Ciaccio. She is a professor of pediatrics and medicine and is the chief of allergy immunology at University of Chicago.
Great. Sorry for the delayed start. So it's my pleasure to talk about prevention of Atopy, something that is near and dear to my heart. I actually got started down this road when I was in Kansas City, and I have just a little bit of data from when I was in Kansas City. But this is somewhere between prevention of Atopy and a work in progress of what's going on in my lab and some of the work that we don't have data for yet, but have works in progress that we are trying to generate the data to support this theoretic framework that I'm going to present today. So when we talk about prevention, I think most people know about primary prevention, secondary prevention, tertiary prevention, but one that often overgets looked is primordial prevention. In my lab, we really try and take a look at all facets of this this pyramid to see how we can intervene and make the lives of our asthma and allergy patients just a little bit better. So a little bit about me and kind of what drives me and the work I'm doing is that I am from the country. I'm from a very, very small town, a very rural environment. In fact, this is my brother on the left with our horse joining us for breakfast in the morning. He can't see it, but our breakfast table is right in front of my brother David. And I was raised in a huge Italian family where we spent many of our hours. And whenever we met around food. It was really very much part of my upbringing and very different than how we eat today. My family brought from Sicily a very Mediterranean diet. So most of our diet was full of whole grains, fruits, vegetables, legumes. We were in the country, we were very physically active at the time. So when I started residency in internal medicine, I was really shocked at this idea of chronic inflammatory disease because no one in my family had it. We didn't deal with hypertension, we didn't deal with high cholesterol, we didn't deal with allergies, and most of my family lived to be well into their 90s, if not over 100, without taking a medicine every day. And I didn't realize that that was a rarity until I started training and seeing kind of this inflammatory cascade that's taken over our bodies and has pointed our immune systems in the wrong direction, probably depending on our genetics, then resulting in cardiac disease or autoimmune disease or, of course, allergic disease. So what my interest kind of sat was, well, you know, I want to go on and do allergy immunology because I really want to study the immune system and I really want to understand what is driving some of this chronic inflammatory disease. And there are several hypotheses for why Atopy is increasing. Here is one framework that I really think about a lot as I'm designing the trials that we're working on here. And basically, we now think about atopic sensitization, at least in newborns, as kind of a race against time. We know very well that if you want the immune system to understand something it senses as safe, it should go through the mouth. If we want the immune system to sense something as not safe, it should go through other epithelial borders. So, you know, very simply put, at the highest level, this is the dual allergen exposure hypothesis that Gideon Lack and others have put forward. But it doesn't tell the whole story, in my opinion. It starts to get in the general direction. Well, kids have eczema, and once they have open wounds, then it's very easy, as you can see over here on the left, for very small food particles that we know are ubiquitous in our environments. We know they're ubiquitous in our environments from work that we did when I was at Kansas City with Charlie Barnes. And we looked in homes Jody Schroba. We looked in homes of folks who had peanut allergy. We looked in homes of folks who did not have peanut allergy. We looked in homes that had peanut restricted. We looked in homes that did not have peanut restricted. And there was peanut allergen in every single home that we looked at. It really did not matter. It's very ubiquitous in our environment. So the dual allergen exposure hypothesis says, well, we have these open wounds, and it's very easy for the very small size of the protein of peanut to get in the wrong way. So part of the reason that we think LEAP worked so well is that we were just very quickly getting food the right way in instead of this wrong way. But it fails a little bit to say, well, why is eczema forming in the first place? Because if we look back even a step further, we know that once kids start getting very dry skin, it has already begun, and we don't have an explanation for that point. And that's where I start to look at nutrition and the microbiome, which go hand in hand. And my hypothesis is, well, children are not born nutritionally replete to actually be able to maintain their epithelial barriers. And if we can re-epithelialize, seal, we can maybe make some movements in some prevention, at least in primary prevention of disease, or at least secondary prevention, I should say. So if we look at some of the microbiome data, whether it's in kids, whether it's in adults, we can see in study after study after study some general trends. And what it comes down to is in infants, they're mostly losing the bifidobacterium, and in adults, they're mostly losing Clostridium species. And what happens with these? Well, several things, but one of the big things is that, oops, hold on. I'm going to go back in a second. One of the big things that we see is a loss of butyrate. So if you do not have, as an adult, Clostridium, and if you do not have bifidobacterium as an infant, many things happen. One, you cannot create butyrate, and if you cannot create butyrate, you get skin damage. If you cannot create butyrate, you do not make enough GABA, and you get too itchy. Another phenomena that happens is if you have the wrong bacteria, if you don't have enough of the Clostridium, if you don't have enough of the bifidobacteria, you're not absorbing the nutrients you need to also prevent atopy. There's very strong links with other things like ferritin levels. So we need those bacteria in our gut to act in this symbiotic way. And the way we think about symbiosis is really the same way that I learned about it first in 6th grade when we learned about a wasp and a fig tree, and how neither can survive without the other. So when I think of our whole system, this is how I think about it. The two organisms that are dependent on each other for survival, of course, are us, our human, and then these beneficial microbes, these commensal microbes that sit in our gut. So what do we give them to grow? So we give them prebiotics. And what are prebiotics? It's fiber. So it's fibrous fruits and vegetables. It's primarily legumes and roots. And if we have a diet full of prebiotics, then we know that we can grow the correct beneficial microbes that help control our immune system. What you may be thinking now is, well, there's been lots of trials on probiotics and they don't work. Well, that is partly true, right? So most probiotics in the store right now are aerobic bacteria, and they are that because if you try and encapsulate anaerobic bacteria, well, it's very hard. They die because there is oxygen all around us. So most of the probiotics that you would find in a grocery store are the very, very good beneficial microbes that we see in infants in their first year of life. And there is some data to support a beneficial effect of eczema if you give those probiotics to very little infants. In adults, we are actually not replacing the bacteria. We are working on that actually here at the University of Chicago. Just last month, we opened the first academic pharmaceutical plant in the country that can encapsulate anaerobic bacteria. So what we are hoping to do is then replace some of these beneficial microbes. As of now, if I, as an adult, takes something from Whole Foods that is a probiotic, it passes right through. And it actually serves as a prebiotic. It helps these microbes grow. but it does not stick. They are not actually the ones that will then help control our immune system. So once we have done something to feed these microbes, what happens? Well, they give us something back that helps us, our survival, that we need for our survival. And these are postbiotics. And these postbiotic things are the things that I just started to introduce, like the short chain fatty acids and things like GABA. So as the microbes are digesting the prebiotic fibers, these are the things they release. And these things, once they're released, they help our immune system. These are just 2 examples, but there are many others that are worth taking a look at. One, just because a colleague of mine is one of the first person to really identify the significance of this in food allergy, we've really focused a lot on butyrate. If you are not making enough butyrate, we know that you have gut barrier disruption. So you get leaky gut. I don't love that term because it runs rampant on Google. But essentially, we can actually see it in the mice that have been sacrificed, that you don't get those nice columnar cells that line up and keep everything that should be in your gut in your gut. So what happens? So food slips right through, and we can see this very clearly in our animal models, that the very, very small size of things like peanut and egg and milk lend itself to fit right through that leaky gut and get into our bloodstream where it should not be, because then it's getting presented to the immune system in the wrong way, even if its initial exposure was through the mouth. And there's another phenomena called pathobionts. So these are those good commensal bacteria, and when they're in our gut, they are in fact good. But if they slip out, because we have barrier wall dysfunction, they become something that we term pathobionts. They actually get into our bloodstream, and not enough to cause an infection that needs to be treated. They are not pathogenic in that way. They're pathogenic to us because then they drive Th2 inflammation, and that Th2 inflammation starts to lead to skin damage. And when we see that skin damage, we start to see kids pop up with eczema. Another example is if you are not making butyrate, you start to get this barrier dysfunction, you actually stop making GABA at the same time. If you're not making GABA, you are not getting the inhibition signal to stop itching. So skin gets very itchy, whether it is dry or not. And then there's direct mechanical damage that the infants are causing to themselves. Okay. So that is the framework, and then here's some of the evidence that I'm working on to kind of support this. This was work that we did with a fellow at the time, Allison Humphrey, and a gentleman who actually worked on geocoding throughout the Kansas City area at UMKC, Ben Wilson. And as you can see, this, I'm sure everyone there is familiar with the Kansas City, is this is the state line. So here is Overland Park. Sorry, in Chicago we have Orland Park, so I have now mixed up Overland Park and Orland Park in almost every conversation I have. We actually have one of our clinics in Orland Park. And then over here, of course, is Kansas City, Missouri, and up here is Kansas City, Kansas. So if it's red, it's actually a food desert. If it's green, it's not a food desert. And as you know, a lot of the wealth is concentrated into this area over here on the Kansas side that is not food deserts. Up here in the pink, and this is old now. So these data, although it wasn't published in 2021, was I think from about 2013 we pulled it. I think things have changed a lot in Kansas City, but this at the time was the distribution for the food deserts. And then we took all of our food allergy diagnoses and then we mapped them on top, and we could see that the food allergy diagnoses clustered very strongly into those food deserts. So this was kind of some of the first evidence that I was able to gather to say, yeah, I mean, this really makes a difference if our nutrition is not correct, that we are lending ourselves to becoming susceptible to developing atopic disease. So I came to Chicago then in 2015 and wanted to continue this work. And I am down here on the south side in Hyde Park. And here are maps of Chicago. So here is Lake Michigan, and then this is the downtown area. And then I'm down right about here. Yeah, right about there. In 2007, it was really a big problem with access to food. It's gotten a little bit better over the years. But I could not find any data that overlapped food allergy, but my partner at Northwestern, Ruchi Gupta, had already mapped asthma diagnoses. And as you can see, these maps are nearly identical. So the green, the darker the green, the less asthma. Once you get to red, it's above 30%. In fact, in neighborhoods by us, we are almost at 50% prevalence now in pediatrics. There's really a huge disparity in the city, but what is the most concerning part is that these areas cluster very tightly around areas that are predominantly Black and African American neighborhoods and not white neighborhoods. So the white neighborhoods tend to have very low incidence and prevalence of asthma, and it's the Black neighborhoods that is really blighted right now. And it's not just the prevalence. We see the hospitalization rates have a clear difference. Anna Bullerman, who's a colleague of mine now at U Chicago, put out this data, but we see a clear difference between the white individuals who live in Chicago, Black, and even Hispanic, who have high rates of asthma across the country. And this is really just evidence to point out that we have to take a look at that primordial prevention part of the pyramid that I initially showed you. We need to there are plenty of reasons in Chicago this happened. You know, one of them is very clear and easy. We live in a food desert, and then when the Dailies were mayor, they ripped out the L line that comes down to where I live. So there's actually very little public transit access into the city from down on the south side, but there is from almost anywhere else in the city. We also live in geographically, and we're two major highways. We kind of live in the center where two major highways actually come into Chicago, and most of the diesel fuel is coming. I don't know if you've seen the data. There's data, of course, out of Cincinnati that was published a long time, Nira Hershey and her group, about how close you are living to the highway and incidence of asthma. Well, then Donald Leung's group actually just mapped that too for atopic dermatitis and showed that if you're within 10 miles of either of these roads, which is everybody here on the south side, then you have a higher incidence of atopic dermatitis as well. And then we know that if you have atopic dermatitis, you're more likely to go on to have asthma and allergy, food allergy. So again, I really just want everyone, as you develop your careers for your fellow, to remember that this does not start on the individual level. This starts on the population level. We need to hold our government accountable to make sure this does not happen. This same phenomena actually happened, I believe it was on the south, if I can remember correctly, the southeast side of Kansas City. The Beltway was built, and it kind of prevented access to most of the resources of the city for an individual group, and it was actually Black individuals who live in Kansas City at the same time. We cannot let our government do that. We need to make sure that everyone has equal access to food, who has equal access to clean air, who have equal access to clean water, or we will never be able to get a hold of this problem of chronic inflammation. Okay, so moving on to primary prevention. Well, what's primary prevention? Primary prevention is when we are trying to stop disease before there is any signs of disease whatsoever. I personally think this is a very difficult target. I started out my career thinking, okay, primary prevention's it, primary prevention's it, primary prevention's it. If we actually want to make a intervention other than just saying you really need to focus on your nutrition, it is very hard to convince a new mother with a baby that does not appear to have any problems to do something specifically to prevent a problem that may not even be in their family. So unless we can really find a specific group, this messaging has been very difficult, and we can see that because the LEAP trial, the data was convincing, so convincing, and the uptake in both here in the United States and across the world has actually been relatively poor. The messaging is out there, but again, families are already exhausted having a new child at home, and to add one more thing, it's just not yet on the radar. It is slowly improving, but here is some data that started us down a path, though, of one primary prevention study that I started this work, actually, Susan Carlson was at KU, and I started thinking about omega-3 fatty acid because that was her work, and she was really responsible for getting a lot of the omega-3 fatty acid into baby formula through many, many studies she did. So I started talking to her about looking at this in allergy. And here is a lovely paper from 1930, the Burrs. It's a husband and wife team of scientists. And what did they do? They actually took their animals and they gave them a diet that had no fat in it whatsoever, and then they made observations about what was happening. So their summary was that we found that the animals who received no fat consumed almost twice as much water as their controls receiving fat in their diet, and that they do not excrete this excess water as urine. So the feces are very dry, very small in amount. The water lost by evaporation reflects in some way both the condition of the skin or lungs or both. It is not known which is involved, but it is quite clear that the lack of dietary fat has so injured the tissues that they are no longer the normal membrane separating the interior of the animal from its relatively dry air environment. I love this. I feel like they just did the very first tool, the transepidermal water loss experiment. They show that we need to have good healthy fats in our diet. I worry about the fat. I'm sure everyone still, well, everyone who's as old as me still remembers that these snack wells in the, I think it was the late 80s, the world tried to tell us we should have no fat in our diets whatsoever, but that's clearly wrong. We need to pay attention to micronutrients. We need to pay attention to macronutrients. And if we get no fat at all, we run the risk of the same thing happening to us that happened to these animals. If you look in humans, the data is also very compelling from numerous studies that show that fatty acids, essential fatty acids, are fundamentally important for maintenance of the skin barrier. Here's all the different things that I could gather, but there's many more papers that you can see that just demonstrates this. And we know that in our diets, omega-3 fatty acids are now very hard to get. We used to have, cows used to be a high omega-3 fatty acid food. We started finishing it with corn. They lost a lot of the fatty acids, so we all started going to salmon. They were high omega-3 fatty acid food. We started farm raising salmon. It's mostly lost the omega-3 fatty acids. So if you live in a food desert where you really have access to gas stations and fast food chains such as McDonald's, it is almost impossible to get adequate amounts of essential fatty acids. So we started something called the NAP study, the Nutrition and Pregnancy Study, and what our hypothesis is that the prenatal DHA levels would have a direct effect on childhood asthma and atopic outcomes. And really what we're interested is in the interaction that plays when you are stressed, because we know omega-3 fatty acid is just one of the ways that can actually dampen our stress response. So we selected a group of mothers that we thought probably had particularly high levels of stress. All these moms, the surrogate that we used is they were all on public assistance of somehow. Most of them were on Medicaid. All were Black mothers, because this has not been studied in a Black population before, only in Caucasian populations. And we separated into 2/3 moms actually actively were supplemented during their pregnancy with omega-3 fatty acids, and then 1/3 was supplemented with a placebo. All gave birth, and now all the children are actually turning 6 years old. So they're coming in one by one, and we're actually trying to see if we had an effect in pregnancy now at age 6 to prevent some of this asthma and atopy. And we're also looking at the stress response to see if we were able to dampen that stress response a little bit. Secondary prevention. So secondary prevention, of course, is when you start first seeing signs of disease. And I think here is a really, really powerful target of us to have an impact. And the reason is because once mom sees that something is starting to go wrong with her child, their skin is very, very dry, it's starting to rash up even a little bit, they know to sound the alarms. I think in general, the public is savvy enough to know about the atopic march, and when they see this, they want to do something to stop what is the inevitable. So for this, we created the SEAL study. My co-investigators are Karin Nadeau, who is our PI for the project, who is now, of course, at Harvard, and Tina Cinder is at Stanford, recruiting from Stanford. Of course, T. Bonson is doing our statistics. He does most of the statistic work in our field now. I'm the PI here at the University of Chicago. Donald Leong is the PI at National Jewish. And then Gideon Leck and Helen Brock are working, and Susan Chan. Susan is a dermatologist in London. The three are working on recruiting from their sites. We are admittedly under recruiting. We started right in the middle of the pandemic. So we've recently approached Neera Hershey's group at Cincinnati Children's to join us. So of course I mentioned the LEAP trial. What did you see in the LEAP trial? Of course, if you early introduction of peanut significantly decreases the risk of developing peanut allergy. So what do we think, right? This race against time. So we know if we can get into the mouth early, we can have some effect. Well, if we can put emollient on the skin and stop entry, can we even buy more time to get food into the mouth and have an even more profound effect? So in a mouse model, we know that all of the over-the-counter moisturizers that were used increased transepidermal water loss and skin surface pH. If we look to human data, we also know that we have a big problem with what we're doing right now. So this is the EAT study. This, of course, was Gideon and Helen's group. 1,300 exclusively breastfed 3-month infants were recruited between 2008 and 2015. The primary outcome was just on questionnaire, and they found that each additional moisturizer application increased the odds of food allergy by 20%. They concluded that the regular application of moisturizers to the skin may promote food allergy. But this was not the only one that made us sound the alarm. Of course, the BEEP study came out, had again 1,400 high-risk infants. The intervention was either this dipper-based cream or a double-based gel. One was a petroleum, one was a fatty acid plus petroleum for the first year of life. One was standard of care. And despite very good adherence in this trial, it did not prevent atopic dermatitis, it did not prevent allergic rhinitis, it did not prevent wheeze, it did not prevent allergic sensitization to cat grass or dust mite, and it did not prevent food allergen. They also were forced to conclude that it may have increased in the emollient group. Prevent et al. Went on and found the same thing. 2,400 infants were randomized into a 1-to-1 to 1-to-1 intervention. Either no advice on skincare, just national guidelines on nutrition, skin emollients, early complementary feeding of peanut, milk, wheat, or egg, or both skin and food intervention combined. This was published in Lancet. And they found that neither the skin emollients nor the early complementary feeding reduced development of atopic dermatitis. The prevalence of food allergy age 3 was reduced in the food intervention group, as they saw in the LEAP trial, but the prevalence of food allergy age 3 was not reduced in the skin intervention group either. So we have a problem with our emollients that we can buy from the store. We really think there is a problem. What about natural treatments in London? And this is actually was published with the EAT data. In London, there is a high incidence of wanting to use olive oil on the skin. And what did Donald Leong find and published just a few years ago? Well, vegetable oil triglycerides actually integrate with our own skin ceramides, and they further disrupt the matrix. So then it facilitates penetration of allergens across the stratum corneum. And we think this is exactly what's happening with any vegetable-based oil. We think on the from what we buy from the store, the petroleum-based emollients may not hasten allergen across the skin, but they trap it against the skin, and they do not. This is Donald's data as well. They do not actually help the skin layer rebuild. So Donald also concluded that olive oil is for eating and not skin moisturization, which caused a nice argument since I'm Italian and I really love my olive oil. He assured me I can continue to eat my olive oil, it just can't go on the skin. So if we look at Donald's data and we start to buy in, yeah, there's a problem with putting petroleum on the skin. What can we do about it? Why do we not just say, well, everyone should use the commercially available moisturizing creams that have ceramides in them, because we know that ceramides can rebuild the skin. Well, they're very, very expensive and they're out of reach for many people. So if we don't prove that this is a therapy that can work and can stop this potential harm that is happening, then this will not be available for folks who cannot afford to buy this for the skin. It's also not been tested on disrupted skin, in all fairness, any of these ceramides, and we really need to make sure, because we're seeing from all this data that's piling up, there's actually even more data since I made this slide presentation. We don't want the same thing to happen with these ceramide-based emollients that we're seeing with the petroleum jelly that is just not working. So this is Tina Cinder at Stanford, her early data, and this is what kind of kicked off our SEAL study. And she used individuals as their own control. So on one arm, she looked at the transepidermal water loss, the tool, to see how high it was. Then they put a Veno cream, that's a petroleum-based emollient, on their skin, and she saw a very little decrease in tool. But when she looked at Episerum, which is a ceramide-based emollient, she found a drastic decrease, highly significant, in transepidermal water loss. We actually saw the skin starting to rebuild. That barrier dysfunction started to reverse itself instead of just putting something over the top. So our overall hypothesis is that if we give proactive skincare targeting infants at high risk for atopic dermatitis, that secondary prevention and high risk of atopic dermatitis will maintain that normal skin barrier function and then prevent the transcutaneous allergen sensitization and development of food allergy. So here's how we designed the trial. We are recruiting 0 actually to 12 weeks now. We've increased it since we've had some trouble with recruitment. And they either go to an arm where they get a trilipid emollient, they get ceramides right on their skin, and they are proactively treated with fluticasone propionate if they have open lesions from atopic dermatitis. The NIH forced us to put in an Aveeno arm temporarily as sun's been dropped, or they go into arm where it's just reactive care. And in the reactive care, it's whatever the primary care doctor wants to do. So we're excited about this because this is different. We're not looking at primary prevention. We're not going to try and ask all mothers to do this. It's when they first start seeing that secondary prevention, when they first start seeing dry skin. We're putting an emollient that we know can rebuild the epithelial layer. We're also making sure that families, their hands are clean. When they put this on, they don't go straight from eating and then put moisturizer on the skin. We're actually reducing all detergents on the skin, which we know can be irritating and can disrupt the skin barrier as well. So that we will finish enrollment of March. In March of next year will be complete, and then our exit point is at 2 years. So in 2027, I should be able to come back and tell you if it was successful or not. I'm very happy with the theoretic framework, but as we know from many other trials, that does not guarantee success by any means. Okay, and then tertiary prevention. What's tertiary prevention? Well, this is really on the most individual level when you have someone in front of you who has the food allergy and they're desperate for something. So 2 things now, thankfully, have been approved as treatment. Of course, these are all our food allergens that we worry about. And kids, we know, are often, almost 50% of the time, sensitized to more than one of these. So it has been very difficult to design tertiary prevention strategies that will help individuals not have a reaction if they are exposed to these foods. But then out in February of this year, of course, comes omalizumab for the treatment of multiple food allergies. Why is this great? Well, this is a drug that it was, of course, repurposed. We've all had lots of experience with it. We are very comfortable with the safety. What's the downside, of course? Well, it's an injection, and many kids don't like that. But it is a step in the right direction. And how does it work? Well, we know, of course, it's an anti-IgE, and it blocks those food-specific IgEs very effectively, because when we look at their data, we could see peanut, cashew, egg, milk, walnut, hazelnut, and wheat all had some effect. Some were not quite as robust as others, cashew particularly, but others really were phenomenal. It's not going to be the last biologic. There are many others that are under investigation at this point, so we're hoping this is one strategy that will work. And then, of course, oral immunotherapy. This was the first approved back in 2020, right before the whole world shut down because of the pandemic. And there are many different ways to do oral immunotherapy at this point. Our clinic, I think yours does as well, even uses foods that are not part of an FDA-approved product at this point. And we start at very low doses, and we slowly increase to try and gain some tolerance or help kids become bite safe. We know this is highly effective, even a short time frame. So this was just 6 months after they reached their maintenance dosing. They had a significant improvement in the amount of peanut they could tolerate without a reaction. Once they had been on it for another year, even without changing the dose, that impact was even greater. What's the downside? Well, there was a lot of discontinuation. In fact, there were 43 that withdrew from adverse events. We know oral immunotherapy, especially when it's on protocol, when it is very quick that they have to increase their doses, was associated with a lot of side effects. I think most of us now take a much more relaxed pace than what were in some of these original studies that we were working on, but it did help us really understand what some of the risks of this are, including a not insignificant amount of acute or chronic recurrent GI symptoms, lots of reflux, lots of cramping pain, and of course we know the development of EOE. So this is one thing that I wanted to tackle because we are a microbiome center here at the University of Chicago, and I wanted to use some of the data that was already generated from my group. And we know that if you take a mouse and you raise it in a completely germ-free environment, the immune system of the gut is very poorly developed. It's missing key components like IgA and those T regulatory cells that are induced by butyrate, which we talked about earlier. And they cannot tolerate highly energetic foods. So those foods that I showed you before, milk, peanut, tree nut, they all have very small proteins, and it's very easy for them to slip across the epithelial border if it is disrupted. But we know that introduction of certain bacteria, pieces of bacteria like Clostridium or lipopolysaccharides, can redevelop the gut immune system, even in these mice that are raised in a germ-free environment, and they can then start tolerating allergenic food. We also saw in Dr. Nago's lab, one of my research partners here, that if she was able to transfer the gut bacteria from a food allergic mouse, and she was able to transfer the gut bacteria from a food allergic child and put it into a mouse that was germ-free, and that mouse, she could actually transfer in a communicable way the food allergy from the human into the mouse, and the symptoms the mouse would display were very similar to the symptoms the child was displaying in response to a milk challenge. She is also the one who first saw that if we adults do not have the Clostridium species, we cannot maintain this integrity of our gut wall, and that we can see that peanut protein leaking straight through into the bloodstream. In the interest of time, since I started late, I'm just going to skip over those mouse data real quick. So what did I decide that I wanted to do? Well, I wanted to see, since we knew that our facility to encapsulate anaerobic bacteria was not going to be ready anytime soon, we thought, well, what if there's a simple nutritional intervention and we can do the same thing as replacing bacteria? So I went back to the literature, and lo and behold, I found a couple things. Well, here is out of Michigan State, and they did a study where they looked at things that we know are prebiotic in nature, such as cornstarch, inulin, and potato starch. And what they found was that there was a significant increase in butyrate and another short-chain fatty acid, acetate or acetic acid, if you consume potato starch every day. Cooked and cooled potatoes is what is considered a prebiotic. And we have some science that suggested why this may happen. Well, we think that there are primary degraders who are actually degrading down these polysaccharides, and we get intermediate products like the acetate and lactate, and then it's these butyrate producing bacteria that make that final change into butyrate. So, I had one more piece of data that I didn't have in the slide, but I was then wondering if we could actually show that, okay, so we can increase butyrate, but can this have an effect on chronic disease? And yes, there is a great study on diabetes out of China where they put them on a prebiotic diet. It was not potato starch, but it was primarily roots and legumes, and they were able to easily show an improvement in hemoglobin A1C once they went on this high fiber diet, as well as shifts in their microbiome. So I'm going to skip through this as well. Here is our pinpoint trial. We're done with enrollment, and we actually have one patient left on study who is waiting to go into their exit food challenge. So I'm hoping in spring next year we will have data to share on this. But what we do is we are enrolling the kids. We're doing a double-blind, placebo-controlled food challenge to peanut. If they are peanut allergic, we prove it. And then we either put them for 30 days either on a placebo, or we put them on potato starch that's just mixed into basically their breakfast. They take a tablespoon of it every day. And we're looking at their gut microbiome the whole way. And then everybody goes through peanut oral immunotherapy. And then they go through an exit food challenge. And then we just put them on extended monitoring for whatever they want to choose to do. Some people have decided to drop the oral immunotherapy altogether. Some are on it. Some have increased the dose even more, up to more like 10 peanuts. I am still blinded. I don't know who received the prebiotic intervention and who was on placebo, but everyone was on oral immunotherapy. So what we're going to look at is if the outcomes were better, if we hit better tolerance when we challenged up to 1 gram on the exit food challenge, and if side effects were reduced, if we could actually start controlling some of those GI side effects. I was very happy to see just recently in Nature Medicine, I believe it's going to be published, a new paper coming out that showed a link between success in oral immunotherapy and the gut microbiome. And what they found was if you're missing these Clostridium species, what you have, if you're having a high carbohydrate diet that is not fibrous, that is very simple sugar, you generate these very efficient bacteria that, very efficiently take calories out of our food. Of course, they can make us then very chubby because we are absorbing everything. We're not excreting an appropriate amount, but they are also breaking down the protein too quickly for the immune system to apparently even do its job to become tolerant. So those who are failing out of desensitization protocols, they have gut bacteria that is degrading that protein too quickly, and we don't want that. So that's all I have for you today. Here is what I'm working towards in my clinic of the future before I retire. I'm very hopeful that we can eventually get away to at least some extent to growth charts. I don't love growth charts. I don't love the idea of equating how much you weigh with your immune system, because by and large it's a very poor biomarker. I think though what we're finding is there may be some other targets where we can get a better biomarkers and look at how our immune system is. So the things I want to focus on is continuing to make sure there is fair and safe access to food and pre-pregnancy, that mom is nutritionally replete before she even becomes pregnant, giving that child the absolute best chance of having a fully developed immune system. And then early in pregnancy, maybe we can even take a look with a variety of stool tests, looking at stool microbiome or looking at certain mediators like omega-3 fatty acids in the blood or ferritin in the blood. If there is any signs of deficiency, at that point we can replace, intervene. In infancy, maybe we'll be able to do the same thing, really get a look and be able to plot on a chart if an infant's immune system looks like it is stable. And then send them into childhood, where only as a last resort we're using these immunomodulatory strategies that we're using now. So thank you very much to everyone who has funded this work, and for you guys all for coming and listening.